Parfait. Alors, vous allez entendre un petit peu de musique pendant que je fais le transfert. Dès que j'enlève la musique, vous serez dans l'appel un moment, s'il vous plaît.
Recording in progress.
This conference is being recorded. Cette conférence est enregistrée.
Okay, good morning everyone. Bonjour tout le monde. Bienvenue à notre conférence de presse. My name is JP Tasker from CBC News and I'll be the moderator for today's press conference. Today we have Dr. Theresa Tam and Dr. Howard New from the Public Health Agency of Canada, who are obviously no strangers to us all. They're here to provide an update on COVID-19 and they'll also be available to take your questions on monkeypox. Okay, doctors, the floor is yours. À vous la parole.
Bonjour à tous. We're actually providing a technical update on monkeypox, but of course we'll be happy to take other questions. Donc, bonjour à toutes et à tous. We are here today to provide an update on our efforts to address cases of monkeypox in Canada. The Public Health Agency of Canada is closely working with international, provincial, and territorial partners to keep Canadians safe. We are closely monitoring emerging data, and as we learn more, our response and advice will continue to evolve. Over the past week, the Public Health Agency of Canada has confirmed a total of 112 cases across the country. This includes 1 case in British Columbia, 4 in Alberta, 9 in Ontario, and 98 in Quebec. Among cases for whom information is available, age range from 20 to 63 years. All cases to date are male, and the majority report having sexual contact with men. However, this virus can spread to anyone through close contact with an infected person. The National Microbiology Lab, or NML, is also performing confirmatory testing on a number of other suspected cases. Therefore, we are preparing for more confirmed cases in the coming days and weeks. In addition, the NML is conducting sequencing of the virus causing Canadian cases. Early results indicate that cases in Canada are related to the international outbreak. Further work is being done to better understand chains of transmission domestically in support of the ongoing outbreak investigation. Working together with provinces and territories, our primary goal is to contain the outbreak. This means rapidly stopping chains of transmission to prevent the establishment of monkeypox in Canada and protect public health and healthcare in Canada. We're also focused on protecting those at the highest risk of severe outcomes, including immunocompromised individuals, pregnant people, and children under 12 years of age. In support of this approach, today, the National Advisory Committee on Immunization, on NACI, released new recommendations for the use of Imvamune, a Health Canada-approved vaccine for immunization against monkeypox. After reviewing the data on the current status of the monkeypox outbreak and evidence on the safety and protection offered by the Imvamune vaccine, NACI recommends a single dose of Imvamune may be offered to individuals with high-risk exposures of a probable or confirmed case of monkeypox or within a setting where transmission is happening, ideally within 4 days of exposure. Affected provinces are currently implementing vaccination strategies based on their local epidemiology. And the Public Health Agency of Canada is currently working with manufacturers to ensure sufficient vaccine supply moving forward and planning with partners to ensure we are equipped to respond effectively to the evolving situation. At this time, a mass vaccination campaign is not needed to address this outbreak in Canada. We have also been developing guidance to support public health and healthcare providers across the country. This includes interim guidance on infection prevention control for suspect, probable, or confirmed monkeypox within healthcare settings, as well as guidance on public health management of cases and contacts. We have met with and continue to engage with stakeholders to help raise awareness of the outbreak and reach communities that may be more at risk with information to help them protect their health and that of their loved ones. With summer holiday with the summer around the corner, people in Canada are gathered for festivals, concerts, and celebrations. Now more than ever, we need to equip individuals with the information they need to plan how they can celebrate safely and reduce their risks of contracting and spreading illness. I want to remind everyone that monkeypox is not limited to just one community. The virus can spread to anyone through close contact with an infected person or their contaminated objects. We continue to ask that all healthcare providers in Canada remain vigilant and closely watch for patients with any symptoms of monkeypox, even atypical presentation, regardless of whether they have reported travel. If you have been in close contact with someone with monkeypox, or you develop symptoms like a new rash or sores on your skin after you had sexual activity or close personal contact with others in the last 21 days, please contact your local public health unit and they will give you instructions on what to do next. As we learn more about the virus, we will continue to provide regular updates to ensure those in Canada have the information they need to stay safe. Information is also available on canada.ca/monkeypox. Thank you. Merci. Megwich.
Bonjour à toutes et à tous.
Good morning to all of you. We are here today to provide an update on our efforts to address cases of monkeypox in Canada. The Public Health Agency of Canada is working closely with international, provincial, and territorial partners to keep Canadians safe. We are closely monitoring emerging data, and as we learn more, our response and advice will continue to evolve. Over the last week, the Public Health Agency of Canada has confirmed a total of 112 cases across the country. This includes 1 case in British Columbia, 4 in Alberta, 9 in Ontario, and 98 in Quebec. Now, with regard to the cases for which information is available, the age ranges between 20 and 63, and until now they are all men, and most of them have said they've had sexual contact with other men. However, the virus can spread to anyone through close contact with an infected person. The National Microbiology Lab, or NML, is also performing confirmatory testing on a number of other suspected cases. Therefore, we are preparing for more confirmed cases in the coming days and weeks. In addition, the NML is conducting sequencing of the virus causing Canadian cases. Early results indicate that cases in Canada are related to the international outbreak. Further work is being done to better understand chains of transmission domestically in support of the ongoing outbreak investigations. Working together with provinces and territories, our primary goal is to contain the outbreak. This means rapidly stopping chains of transmission to prevent the establishment of monkeypox in Canada and protect public health and healthcare in Canada. We are also focused on protecting vulnerable populations in Canada, including immunocompromised individuals, pregnant people, and children under the age of 12. In support of this approach, today, the National Advisory Committee on Immunization, or NACI, released new recommendations for the use of Imvamune, a Health Canada-approved vaccine for immunization against monkeypox. After reviewing the data on the current status of the monkeypox outbreak and evidence on the safety and protection offered by the Imvamune vaccine, NACI recommends that a single dose of Imvamune may be offered to individuals with high-risk exposures of a probable or confirmed case of monkeypox, or within a setting where transmission is happening, ideally within 4 days of exposure. Affected provinces are currently implementing vaccination strategies based on their local epidemiology, and the Public Health Agency of Canada is currently working with manufacturers to ensure sufficient vaccine supply moving forward and planning with partners to ensure we are equipped to respond effectively to the evolving situation. At this time, mass vaccination is not needed in Canada. We've also been developing guidance to support public health and healthcare workers across the country. This includes interim guidance on infection prevention and control for suspect, probable, or confirmed monkeypox within healthcare settings, as well as guidance on public health management of cases and contacts. We have met with and continue to engage with stakeholders to help raise awareness of the outbreak and reach communities that may be more at risk with information to help them protect their health and that of their loved ones. With summer just around the corner, people in Canada are getting together for festivals and concerts and celebrations. So now more than ever, we need to equip people with the information they need to plan how they can celebrate safely and reduce their risks of contracting and spreading illness. I'd like to remind everyone that monkeypox is not limited to just one community. The virus can spread to anyone through close contact with an infected person or their contaminated objects. We continue to ask that all healthcare providers in Canada remain vigilant and closely watch for patients with any symptoms of monkeypox, even atypical presentation, regardless of whether they have reported travel. If you've been in close contact with someone with monkeypox, or if you develop symptoms like a new rash or sores on your skin after you've had sexual activity or close personal contact with others in the last 21 days, please contact your local public health unit and they will give you instructions on what to do next. As we learn more about the virus, we'll continue to provide regular updates to ensure people in Canada have the information they need to stay safe. Information is also available on canada.ca/monkeypox. Thank you. Miigwech.
All right, thank you, doctors. We'll now turn to the question period part of this. Participants who are online, please raise your hands using the raise hand function on Zoom, and we'll work our way through the list. Our first question this morning is from Rachel Haynes at CTV News. Please go ahead.
Hi, doctors. Rachel Haynes here from CTV National News. Thank you for the update on monkeypox, but my questions are actually related to COVID-19 and our current mandates that are in place right now. And my question to you is, do you think that there still needs to be vaccine mandates in place for travel in Canada?
Well, as I've said before, I think the relevant ministers are looking at those mandates as we speak. We are providing information to support their decision-making. And I think I would ask that you go back to the relevant departments on their decision-making process.
Follow up, Rachel?
Thank you, Doctor. But I would love to know a little bit more about this information and the advice that you're providing to these relevant ministers. As Canada's Chief Public Health Officer, is there a justification for keeping vaccine mandates in place? Or can you tell us what is the advice, the public health advice that you are giving to these ministers?
Well, I think first of all, I would want to remind everyone that the people in Canada have done extremely well in, I think, taking up vaccinations. The vaccine mandates or requirements, as they were enacted late last year, were implemented at a time when this was pre-Omicron, with the Delta variant was escalating with some serious signs of serious outcomes. And I think at that time, there was a very good vaccine effectiveness against both infection and therefore likely transmission and against serious outcomes. When Omicron emerged, I think that changed the landscape for COVID-19. That is to say that we're very grateful that the vaccines are still very effective against serious outcomes, particularly after a booster. And that third dose is actually important, but it still works really well. I think what the data being examined is the vaccine effectiveness against infection and potential risk to people in workplaces and in the travel corridor. And so the data has been presented, and I just want to clarify that 2 doses is not enough to provide vaccine effectiveness against Omicron infection, and because the immunity wanes after about over time, and certainly by 6 months. So you need a booster or a third dose rather to be to bring that immunity back up. And the vaccine effectiveness against infection is modest, but it's not nothing. I think that's something that people have to bear in mind. It's around, depending on the study, it's around 50-60% if you get boosted, and it will wane over time, and we're just monitoring that at the moment. So all of that scientific information is taken into account, but that's not the only consideration that the relevant employers or the ministers have to take into account. And given that vaccines are imperfect, though still provide some protection against infection and transmission to others, there are layers of protection that are still needed, such as masking. So they can't just make one singular decision. They have to look at the suite of protective measures to keep employees, workplaces, and the travel corridor as safe as we can. The other advice I think we give is pertaining to the domestic and global epidemiology. And right now we are on a better trajectory in terms of the cases and hospitalizations, but many hospitals still have a lot of patients with COVID, and we are still experiencing quite a number of deaths per day. So it's still very much with us, the pandemic, but we are in a better state in terms of epidemiology. And globally, I think it's unpredictable. The global trend is down in terms of epidemiology, in terms of the cases, and that's great. But as you can see, other variants are emerging. The situation can change, and we need to prepare for sure towards the fall and winter period. So it's not an easy decision to make, but I think those are the relevant kind of data that it can be provided, including also the coverage right now for the booster dose. They'll take all of that into account as they're making their decisions.
Okay, the next person on my list is Laurence Martin, Radio-Canada. À vous la parole.
Laurence Martin, Radio-Canada.
Laurence, I think you have to unmute yourself.
All right. Can you hear me now?
Yes, we can. Go ahead.
Okay, great. Bonjour, ma question est pour le docteur New.
Hello, my question is for Dr. New. With regard to random tests at the border, so say you're a Canadian traveler, you're coming back to Canada. How many days after arrival at the airport does the test have to be done so the virus can be detected before it spreads in the community? Thank you for the question. That's a good question. And I can tell you that we are always analyzing the latest data, and the science continues to evolve. However, I can tell you that we will be making recommendations to lawmakers with regard to random testing at the border. There's always something that can be done to streamline the process. So to answer your question, I think we need to look at other ways to detect the virus. It doesn't need to happen at the airport. It could happen elsewhere. So you talked about transmission in your question. So we need to detect the virus to prevent transmission, but we also need to have an extra layer of protection because there might be the emergence of new variants of concern. So we could also do tracing within the country. So if your question is when is the right time to screen, is it at the border in the interest of preventing transmission? Well, we know that even with the vaccines are very effective, and 3 doses are more effective than 2 to protect yourself against any serious effects and against infection. But they're not 100% effective. So there's still the possibility, the potential of transmission, even if you are vaccinated. So it's important to have different levels of protection, including wearing a mask. It's become a personal decision in some areas, but we are keeping an eye on the situation, and we will improve our recommendations to lawmakers because there's always room for improvement when it comes to screening, either at the border or elsewhere in the country. Dr. New, I'm sorry, that was not my question. I just want to know how soon after a traveler enters the country does the test have to be carried out? For instance, there's the case of passengers who've waited for 2 weeks after coming into the country to do their test. But is that too late? Will the virus already have spread in the community? So how many days after entering the country should a person get tested? I apologize if I did not properly answer your question the first time. So to answer your question, the sooner the better. As soon as a person enters the country, if he or she is chosen for random testing, it should happen within a few days within arrival. A few weeks later is not ideal. But as I've already said, even if a test is carried out as soon as a person enters the country or even later, it's really important for people who come back to the country to engage in good practices at the individual level, and if they have been contaminated, therefore it's important to keep on being careful, to use protection, to prevent transmission. So to answer your question, a few weeks after arrival, it's not ideal to do a random test, but it's still important to keep on being vigilant, being careful, using the right protective measures even several weeks after arrival.
You're next.
Thank you very much. I'm going to return a little bit to the first question you were asked about, because there has been a lot of debate in the House of Commons about vaccine mandates and being lifted for travel, both domestically and internationally. How comfortable are you with the idea of those vaccine mandates being lifted? Because as you mentioned, there are a number of factors the government will have to weigh, but I'm wondering what you are thinking.
Well, I think at the time vaccine mandates were put in place, we were not absolutely certain how effective they would be. After they were announced or around the period that they were put in place, there was an increase in vaccine coverage, somewhere between 5 to 8%. But at the same time, the provinces and territories also had their requirements for vaccines. So I think the effectiveness could be different at this point in time. Personally, I think that we have to do all the other things that supports people to get vaccinated and reduce transmission. For example, there's many reasons why people haven't got up to date with their vaccinations, and we need to do all the other things. When decision makers consider mandates, they're but one tool for increasing vaccine coverage. We have to understand why people are not getting up-to-date vaccinations and address those gaps and questions, including access, including the understanding of why it's important to do so, and answer the questions, and also do appropriate empowerment of the communities and the trusted leaders. All of those things that we, I think, very successfully did in the initial vaccination campaigns, give a PHAC to all Canadians, have to be put in place too. You can't just have something like a vaccine mandate working on its own. And so I think, it's important to look at all the other measures.
When you do look at the various measures that are across the country in terms of public health restrictions, are there any that we don't need anymore that could be lifted, or are there some that people are lifting that you think should stay in place?
As I said, we're in a bit of a transition period. We know what works. Vaccines are important, and getting up to date with vaccination is important. And adding on top of that layer of masking does work. The question is whether they should be required versus a recommendation. And I think quite a few weeks ago, I said, this is going to be a difficult transition period. There'll be many people who think, well, without some requirement, people won't know what to do. And I am immunocompromised. I want other people around me to be protected as well. I feel much safer as a result. But at the same time, one has got to get a better balance and transition to a point where we are empowering the public to think of masking and vaccination as a regular personal protective behavior or routine. So wearing a mask this coming fall and winter, I think people should think of as routine practice. But the transition from requirements to recommendation is going to be a tricky one and may not happen all at the same time or in the same similar manner because populations are different. I think chief medical officers across the country are trying to think through this transition with their own particular communities in mind. But for federal government, they have a very different set of communities or populations, not the least of which is the rest of the world and what's happening there as well, and trying to protect the domestic epidemiology and domestic health systems. So there's different dimensions to that decision making. But I do think what we're seeing and all your questions are related to this rather difficult transition.
Okay. Marie Vastel, Le Devoir.
Hi, I'm going to continue on that, Dr. Tam, if that's okay. I wanted to also circle back to what you said earlier. You mentioned that the 2 doses isn't enough anymore, and the effectiveness, even with the booster, is, I think you said 50 to 60%. Can you tell us what the percentage of effectiveness is for 2 doses of vaccine? And in that following that, if you're saying it's not enough, and I suspect the level of effectiveness will be less than 50, 60% for 2 doses, are you recommending to require then 3 to 4 doses, or to just perhaps, as you said, go through this transition by encouraging instead of requiring 3 to 4 doses?
Yes, so the vaccine effectiveness question is quite complicated, so I'll try to unpack that. There's vaccine effectiveness of 2 dose or 3 dose or more against different outcomes. So vaccine effectiveness against infection and onward transmission, as well as vaccine effectiveness against the more serious outcomes. And so we know that with prior to Omicron, 2 doses of vaccine were highly effective against getting infected. Even with the arrival of the Delta variant, there was some diminution over time as well, but still really quite good. And the 2-dose vaccine effectiveness against serious outcome at the time was very good. But with the arrival of the Omicron variant, that changed things because it's immune evasive. The spike protein is so different from the previous variants that changed the epidemic dynamics. And so you're seeing much more transmissible virus. Vaccine effectiveness for 2 doses waned over time, so that by the time you're about 6 months out or more from the 2-dose vaccination, that you have very little protection against infection. But still, there's significant protection still against serious outcomes. With a 3rd dose, you boost your vaccine effectiveness against infection. Depending on the study, the population studied, somewhere around the 50 to 60% mark soon after you get that 3rd dose. We're monitoring right now how that effectiveness diminishes over time. Now, remember that for some other vaccines, such as influenza vaccine, something like a 50% or over vaccine effectiveness, we would be overjoyed. So it's nothing, but it does diminish over time. But 3 doses boost your immunity against serious outcomes to over 90%, which is why, together with the chief medical officers, the National Advisory Committee on Immunization, we're really focused on trying to get people up to date, including additional doses, depending on age group, your 4th dose as well, at this point in time. And so I think that's the concept people have to begin to understand. I think towards the fall, we'll be looking at the potential for an increase in activity, and immunization programs across Canada are gearing up to support Canadians to get vaccinated at that time. So that's just the foundational background to answer your question. And I think, as you've seen in many jurisdictions, vaccine requirements have been lifted, and asking people to get up to date and do the thing that will protect them and their families. I think the federal government is now having to examine whether mandates will have additional benefit or whether there should be a shift in posture. So that is, as I said, actively being examined by the relevant ministers.
It's Dr. New.
Can I just, because this really, I'm sorry, Dr. Tam, with all due respect, it didn't answer my question with facts and the statistics that I was asking. And I feel like I'm going to lose my follow-up by repeating my question. If I can get a follow-up, that would be great, though. What I'm trying to understand, you have a percentage for the effectiveness after a 3rd dose with Omicron. I would like to know, I know that it wanes after 2 doses after 6 months. What I would like to know is, do you have a percentage of effectiveness after 2 doses and presumably over 6 months at this point for most people? Because the current vaccination mandate is 2 doses. I'm trying to assess what the effectiveness of those 2 doses is right now with the current mandate. And then the second part of my question was, I understand the decision is up to the relevant departments and ministers, but as the Director of Public Health, do you believe that it should be required to up to 3 or even 4 doses to follow the need for effectiveness? Or do you privilege or privilegiate, or do you prefer the approach of encouraging people to get a vaccination, as you said, might be where we're heading with this transition?
Yes. So I thought I answered your question, but maybe I'll repeat it. So after 6 months with 2 doses, the vaccine effectiveness against Omicron is very low.
Yeah, but you have a percentage.
There's so many studies and they're variable, but 20% or less, I would say.
Okay.
Yeah.
Right? So there's almost no protection from infection, but still quite a good protection against severe outcomes. And I think, and that diminishes over time, but really still quite robust. I think people have to remember that the first 2 doses are the most important doses of the vaccine series.
But do you have a percentage, sorry, for the outcomes? Because I'm really asking you for numbers. I appreciate the ones for...
I will give you the outcomes. Two doses, Omicron, with vaccine effectiveness shortly after the last dose for 2 doses is 50 to 80% within the first month, diminishes to about 20% or less after 6 months. Okay. Severe illness, 65 to 85% range, very wide range, depending on the study and the population and the age, etc. But pretty good. For 3 doses, your starting point is about 50, 60, 60%. Again, a range, 40 to 80% in the initial studies. It will decline over time, but we haven't got enough data points at this moment. We expect that to come down. For severe disease, it's over 90% for the 3rd dose. Now, it may diminish over time. A variant could come along, BA4, BA5, that could reduce the effectiveness as well. So it's never a static number. It's going to have to be watched over time. Is that clearer?
Yeah, it's Dr. New.
Thank you very much for the numbers. I appreciate it. And if you could tell me if now you think we should up the mandate to 3 to 4 doses or just transition to recommendation, that would be great.
So I think together with the Chief Medical Officer, we already recommended that people should get up to date. So that is our bottom line recommendation, is depending, of course, on your age, your risk status, and according to the recommendations of NACI, we're going to give this a push towards the fall as people gather and resume full activities. So that is really my position. And mandate is a policy decision that takes into account many different factors, and it's up to the policymakers at this time to make that difficult decision. But I would always be going with recommending up to date. The difficulty, I think, right now is that the federal definition of vaccine mandates is for administrative or travel or other purposes is not up to date. And I am encouraging everybody to adopt the definition, however they look at the policy, to reflect the up-to-date need to have the best protection.
It's Dr. New. Maybe I could just add some additional points to what Dr. Tam has already said. You know, as she said, the whole issue of immunizations and number of doses is complex. And I would say that we can't just focus, quote, on the number of doses that any given individual has received. For example, if you received 2 doses early in 2020 with a very short interval, I would say that your protection certainly is not the same as someone who received their 2 doses later with, let's say, a longer interval, let's say 8 weeks or more. So it's not as straightforward in terms of just the number of doses. The other point that Dr. Tam has said, I would repeat, is that yes, because there are different individuals, populations with varying levels of risk, it's more important to not focus specifically on, you quote, the number of doses, but remaining up to date with your vaccination. Obviously, also depending on local context, so that you have the most or up to date protection possible. And certainly, we've seen that a 3rd dose certainly is very helpful. It certainly gives a good protection. But we've seen over time that the vaccines, in terms of overall protection at a population level, even for individuals, starts to wane, and is maybe after 6 months, that's when maybe is a ideal time to get that 3rd dose. The other point, though, is that I think Dr. Tam and myself and public health officials, ideally in a perfect world, we want to increase vaccine coverage, right? And the great way that I think Canadians have responded to making an informed decision based on the science and getting good information so that they understand why it is good for themselves and their loved ones to get vaccinated. I think that's the ideal way. If you talk about mandates, that's certainly, quote, another tool in the toolbox, and that's something that certainly the decision makers also use to varying degrees as a policy option. But that's different from, let's say, the public health perspective, where we really want vaccine coverage as high as possible. And ideally, it's always with sort of an informed decision that people really see that there's a benefit for themselves and for others. Thank you.
Okay, thank you. Mylène Crête, La Presse.
Mylène Crête, La Presse. Good morning. I would like to know, are you willing at the Public Health Agency of Canada to recommend the end of random testing for air travel passengers coming to Canada, as the U.S. has just done? This is Dr. New. Thank you for the question. Yes, I think the situation is evolving, as we've already said. But what we do at our border with the random screening, it's another way of monitoring the situation and to see if there are any emerging variants which may have appeared elsewhere and which might have made their way to Canada. So the random testing is a way to see if there are any new variants of concern. So we are continuing with screening, even within the country, to see if there are any new variants of concern. It's a good question. But for now, all I can say is that it's something that lawmakers are looking at. And if they do decide to keep some kind of monitoring system in place, things can be done at the border, but things could also be done within the country itself. So we're at that point now. But we have to keep an eye on the situation to see if new variants of concern have emerged. The change of policy in the U.S. Has to do with, applies before passengers arrive in the U.S., but it hasn't changed the random testing in the U.S. In Canada, we've already eliminated pre-tests for vaccinated travelers arriving in Canada, but we have maintained testing for unvaccinated travelers. That's just a clarification. Thank you very much. I appreciate that. I was also wondering whether you have data which might point to a new wave in Nova Scotia, more specifically in Halifax. I've been told that used water tests have shown that COVID-19 is up in wastewater. Dr. New here? Well, clearly, monitoring wastewater across the country shows that the virus is acting up differently in different regions. So at this point here, I cannot say definitively that there is a rise in cases in Nova Scotia, but it might be a signal that something is happening. However, it's not up to us to assert that. It's authorities in Nova Scotia who are on the ground who can make a statement to that effect. As the sixth wave is behind us across the country, and normally in the summer, the virus is less prevalent than in the winter. So I think that we're in a good space right now. However, it's always important to keep on monitoring the situation because we do not know what might happen in the fall and in the winter when people start gathering indoors.
Okay, Marie Wolf, Canadian Press, go ahead. Marie, you are still muted. Please unmute yourself.
Yeah. Can you hear me now? Dr. Tam, I just wondered if you could clarify something you said about monkeypox earlier, where you said that NACI recommends a single dose for people with high-risk exposures, and then you said that possibly they should have a vaccine 4 days within exposure. But how will people know what a high-risk exposure is? And could you just clarify what the actual advice is and how whether people should rush to get a vaccination, because I think this is something that people are not entirely clear what a high-risk exposure is.
Thank you for that question, and I think we are providing some of that information on our website. So this virus is transmitted, as far as we know, we're still collecting information, mainly through close physical contact. So someone who has been in contact skin to skin, or a ulcer or something with skin or the mucous membranes of a person infected, through some of the intimate sexual contacts is very close, as you can potentially envisage, and also with direct contact with objects like bed linen and blankets or such of contaminated with the bodily fluids or the scab of someone who is infected. And also, we're looking at the potential risk via respiratory route. I think respiratory droplet infection through close contact is certainly possible. I think more is being looked at in terms of aerosols, but we know that so far it's really the transmission seems to be limited to that kind of close contact. So by high risk, if you think it more simplistically, are really people who've had these intimate contacts or household contacts, or maybe a healthcare worker who's been working without appropriate personal protective equipment at the time. And the NACI recommendation is for the vaccine, one dose be offered to someone who knows that they've been in contact with a case or they've been in a high-risk exposure setting. And those are the ones that are being communicated at the local level from local public health. And they are working with the businesses or settings where cases have occurred to try and contact clients and people who visited those settings. And that's happening, for example, right now in Montreal. They're also offering the vaccine to gay bisexual men who have sex with men who have had multiple partners in the last 2 weeks. So that's a bit more precision or detail. But for the general population, the risk at the present time is low. But what we want to do is prevent further transmission, particularly to people at highest risk, such as pregnant women, younger children, and those who are immunocompromised.
Thank you for that. Could I ask you a similar question to some of my colleagues about restrictions on travel, including random testing for COVID at airports and vaccine mandates? I wasn't entirely clear from your previous replies what your view is and whether you thought the circumstances are right now to relax travel rules and mandates. And if you feel that they are not, the time is not right, what is the scientific rationale for maintaining them?
Yeah, so I think I'm going to essentially repeat what I've just said, but let's just tackle the mandatory random testing at the moment. So the mandatory random testing is set up as part of our monitoring and detection of the viruses and the variants of concern. We don't test everyone. We test a percentage of the incoming travelers. There's tens of thousands of people coming in a day. We do a randomized sample to select people coming from different areas of the world and are able to detect variants of concern, including BA4, BA5, where it's emerging from. And that acts as an early warning system. So I think that has to be sort of separated from, the other objectives. Is that clear? I'm not sure if you have a question on that first.
I've already cut her off, so we're moving on to the next person. Olivier Ferrand-Boisé from TVA.
Oui, bonjour.
Yes, good morning.
Hi. Okay, can you hear me? Yes?
We can. Go ahead.
Okay, merci.
Thank you. I'd like to come back to monkeypox and to the numbers and statistics. Last week, on Friday, there were 71 cases in Quebec. It was the double of what it had been the previous week, so the numbers are up quickly. Now we're at 98 cases, but the cases seem to be rising less quickly. Do you believe this is partly due to prevention and the vaccination which has been put into effect? Do you think that's made a difference? And if so, how can you predict what might come next? Dr. New here, thank you for the question. Well, frankly, I think it's too soon to reach any conclusions. I believe that local health authorities in Montreal and also those in Quebec are continuing to work on the situation. There are different aspects to the situation, and really it's a matter of working closely with affected communities. It's a matter of collecting information to sensitize people in case they've been in close contact with someone who may have had monkeypox or who are showing symptoms. These people should report to health authorities, and if people feel they are at risk, they should engage in procedures and behavior that would limit any potential transmission. So that would apply to anyone who may have been in contact with monkeypox or who have had it. The vaccine is just another tool in the toolbox. And as far as I understand, health authorities in Montreal are using a very strategic and flexible approach. Clearly, anyone who's been in close contact with someone who's had monkeypox and who's been identified as such should get the vaccine, but also people who have had anonymous direct contact with other people, and they should also be getting vaccinated. Also, people who are close to an area where there has been an outbreak. So these people would all be offered the vaccine to limit any fallout. In the coming days and weeks, we'll monitor the situation. We'll see how the epidemiological curve varies in Quebec and in the rest of the country. Thank you very much. I'd like to come back to an issue raised by one of my colleagues earlier. Dr. Tam was saying that 2 doses against Omicron only provides 20% protection after a certain period of time. Last week, Dr. New, I asked whether scientifically, is there a justification to require vaccine mandates for federal public servants? You said that politicians, lawmakers are the ones who will make those decisions. So now my question is, what is your recommendation now? And do you feel that maintaining this vaccine mandate is aligned with recommendations you're making? Well, thank you for the question. I do understand that the government and lawmakers are taking all factors and options into consideration. Dr. Tam and myself are providing advice as well as other experts. And as the evidence comes in, we will keep on providing advice, but there are many factors to take into account, but as Dr. Tam and myself said, it's difficult for lawmakers and government because not only scientific advice has to be taken into account, but other factors as well. As I've already said, if we want to increase vaccine coverage, it's a matter of making Canadians aware, providing them with information so they can make an enlightened decision, and so people can decide whether they want 2 doses or 3. And even for elderly people, we recommend a 4th dose. But again, there are many factors lawmakers have to take into account.
Okay, thank you. Next is Adam Miller from CBC News. Go ahead.
Hi there. Thanks for taking my questions. I wanted to ask about testing around monkeypox, and how widespread is Canada's testing strategy for monkeypox, and are we doing any surveillance testing in the community to find asymptomatic cases, or are cases only getting tested after patients present with symptoms?
Thank you for that question. And so, for the most part, of course, we're learning all the time about this virus, which we haven't seen outside of the African countries. there's a very significant clinical feature, which is that of skin lesions. So right now, with the dissemination of information to clinicians, they're watching out for rashes and, of course, clinical history of contacts. But they are testing quite a lot of people who are actually testing negative for monkeypox, but positive for other things. So that's one way of casting the net somewhat wide in the front lines of public health. And some of these individuals who are tested actually had very minimal skin lesions, but they are still being tested, and we are finding other causes. The other thing is we are looking at some of the other surveillance systems and through sexual health clinics as well to test more widely. But we are, of course, still looking at new platforms like wastewater and other surveillance systems to see if they can be helpful as well. From a more research perspective, I would say, or epidemiologic study, we are trying to see if there's any way of casting the net wider to look at antibody levels in different populations as well. But right now, I think it's the astute clinician on the front lines who are using a fairly low threshold to test people who may have a rash. This is not like COVID, of course. It's very difficult. Many people have very non-distinct symptoms, but the rash is definitely a clue in this case.
Yeah. It's Dr. New. The only other point I would add is to say with respect to the testing, as you know, initially all of the initial samples were sent to our National Microbiology Laboratory in Winnipeg for that sort of determination, confirmation of what we call lab diagnosis. But the lab in Winnipeg has been working very closely with the provincial labs across the country, and right now is pushing out what I would call technology transfer, so that provincial labs, let's say for example in Quebec and others, will be able, and I think at the present time are already capable of doing their own testing. There's certainly a period in which there might be, quote, quality assurance, confirmation by the NML, but at a certain point in time, certainly the provinces, territories, with the laboratories will be able to do their own testing, which would also help in terms of turnaround times. It would help clinicians and others in terms of more quickly being able to, manage cases and contacts and so on. So that's another thing that we're doing at the national level. Thank you.
Follow up, Adam?
Okay, great. That was going to be my next question, is just what's being done to try to address that backlog. Are we any closer to finding the source of the monkeypox outbreaks in Quebec and other provinces? Like, I know contact tracing is tough in some of these networks, but, Quebec especially has seen such a dramatic rise in cases in the past, couple of weeks. Are we any closer to figuring out the source of that and what exactly was driving such a high number there as opposed to other provinces?
Yes, so I think the genetic analysis is showing that our current outbreak is connected to the international one, at least from a genomics perspective. So we're part of that bigger picture. There are certain settings, the local public health unit thinks what might be, I guess the term is somewhat these mini super spreading events where there was a lot of close contact, including sexual contact. So those details are at the local level, and they are working with those establishments, but there isn't maybe a singular event. There may be a few of them that could have initiated some of the chains of transmission in Canada. I think some of the initial increase in cases, of course, represents some of the retrospective acquisition, sort of data. And we're looking at the usual I think the local authorities are trying to plot that epidemic curve to go back to, well, what is the initial date of the first case. So that is still being investigated, but there are certain settings, and that's why NACI is also recommending that a vaccine could be offered, not just because contact tracing is very difficult. Some of the contacts cannot be easily traced. And so using these settings-based approaches, we will be able to move faster with stopping chains of transmission. But I haven't heard of a singular event as such, but really a social network, if you like, of clustering at the moment.
Okay, I only have 2 people left on my list. Let's try and squeeze them in the next couple of minutes. Pierre Saint-Arnaud, de La Presse Canadienne.
Pierre Saint-Arnaud, La Presse Canadienne. Can you hear me, Dr. New? Yes. I have 2 questions, 2 simple questions. So, do we have a number, or do we know approximately how many suspect cases of monkeypox, in addition to the confirmed ones? You're talking about monkeypox? Yes, I am. No, we don't, because the provinces and the territories have those numbers. Quebec might have more suspect cases, but Quebec has the ability to do laboratory testing and tracing. So it's a matter of keeping an eye on the situation in Quebec, and given what we've seen in the last few days, there has been an increase, and we are hoping that with the strategy put in place and the monitoring of the situation and offering the vaccine and keeping an eye on high-risk activities, this might help temper down the curve. My second question is this. At the beginning of the epidemic, it was said that Canada had an unlimited quantity of vaccines, but for security reasons, the number wasn't given. Given that the outbreak is spreading, has that approach changed? Have vaccines been added? Have we bought them from elsewhere? Or do we still have the same number of vaccines, which is limited? Thank you for the question. I think that, as we said in our opening statement, the Government of Canada is still working with manufacturers to purchase more vaccines, but I can tell you that we don't have an unlimited quantity. It's important to supply more vaccines and to bear in mind that it's always possible to have another outbreak of monkeypox or other types of illnesses. But in Quebec, we've seen, and it's starting in Ontario, we've had very good conversations with our Quebec and Ontario counterparts. And here at the agency, we certainly are in agreement with their strategy of offering vaccines not only to confirmed cases, but also to persons who have been at events where they may have come into contact with someone who has monkeypox, where there's a high risk for these people. But we have to manage expectations, so we are keeping an eye on how the situation is evolving. Now, we don't have an unlimited quantity of doses available, but with a good strategic approach, with a prudent approach, we believe it is possible to contain the outbreak. We're only at the beginning here, but if we act now, we have a better chance of preventing the monkeypox from becoming established in Canada.
Raisa Patel, Toronto Star. Go ahead. Please unmute yourself, Raisa.
Can you hear me now?
We can. Go ahead.
Yes.
Okay, thank you. I wanted to go back to random testing at airports. You know, from the end of February until the end of May, just under 3% of all random COVID tests at airports came back positive. I mean, that's still more than 8,000 positive tests. So does that figure signal to you that random testing is still a necessary measure at airports specifically? Is that a significant number?
Yeah, I think the random testing is not to detect every case. It's there to provide an early warning system for variants of concern. And you've got great numbers. I'm very impressed that you're so up to date. I think we do post them on our website. But yeah, I mean, 3 out of 100, tested are positive. So we can trend those as well. And when the global epidemic curve goes up, and as you can imagine, some of the positivity rate goes up with the Omicron wave, and it's maybe coming down. But that's quite just a message alone that travelers, wherever you're coming from, 3 out of 100 of people coming across may be positive. So those statistics are important for trending measures, but really the early warning on variants is important. And for that, it's not just the numbers of tests, it's the stratification, making sure we get samples from people who are arriving from different areas of the world. Most of them, of course, do come through the biggest airports. And so we focus some of the sampling accordingly so that it gives us a robust estimate, and the confidence intervals are such that we can use those statistics more effectively. So the calculations for the number of tests being done at a given time is based on statistical analysis of whether we will have a good chance of picking up variants of concern. So we believe that at the moment, the sampling frame is such that we can, and we have been able to trend some of the incoming signals, for example, for BA4 and 5.
And just to go back to vaccine mandates for travel for a moment, we keep hearing from politicians that they're following the science on that requirement. But when it comes to that science, which is your jurisdiction, what metrics specifically are you looking at to make that determination that mandates are no longer needed? What figures are you looking at? What kinds of numbers or thresholds would signal that we don't need to have those federal mandates anymore?
Yes, so it's a complex decision-making process, and the data forms one really key foundational input. And I think right now, what we're seeing, even though the cases and trends are still fairly high, that there is epidemiologically in Canada, things are going in the right direction. So that's one thing. I mean, I'm not going to give you the number of cases or the number of hospitalizations a day, because that's really quite complicated. Whether the health system is able to cope at one end of the country to the other is actually quite different. And so, but we do have to look at healthcare system capacity and the hospitalizations, and they are trending down. So that is important. And we can't just calculate how many beds are occupied per day. That would not be a reasonable way of looking at things, but still a trend. And the talking to jurisdictions, making sure that their systems are coping. Of course, there's lots of backlogs and stuff, but in terms of at least the COVID hospitalization is trending down. We, at least for the international data, have to look at the world and the global data and what's happening in the United States, for example. And again, most trends are coming down, which is good news, and that we convey to decision makers. Of course, there's uncertainty into the future as to when the next wave might come, and certainly getting ready for the fall. So when they then make the decisions and we say, well, the global trend is looking better, and some of the testing that we're doing at the moment, we will take into account that mandatory random testing and its percentage. And so these trends are all moving in the right direction. So it's not a threshold or exact number. The other thing, of course, is the vaccine coverage levels, which has been remarkable for the first 2 doses. And for the booster dose, it is less than 50% still of the total population, but quite good in the highest risk groups. So they will take that into account. So there is a gap. There is some ways to go for maybe improving on that 3rd dose. And so they will look at that take that into account. But still, I still think we're doing pretty well. And so that's the type of context that upon which the other considerations for policy making has to take place. And but I do know that when decision makers are having some of these difficult debates, they do have one thing in mind, which is reducing deaths, reducing long-term outcomes. And so they are taking it very seriously. It's not an easy decision, but I think some of the conditions and the epidemiologic parameters are looking quite good at this point.
Thank you, Dr. Tam, and thank you, Dr. New. I appreciate you giving us a few extra minutes today because we did have a lot of people on the line, lots of interest as usual. That concludes today's press conference. Everybody have a great rest of your Friday and a good weekend. Merci à tous.
Thank you.
Thank you.
Have a good weekend. Bonne fin de semaine.